Right, good afternoon to everybody. Now, when you're ready, Mr. Turner.
Thank you, Lord. Good afternoon. The next area I would like to speak to you about is questions of sustainability of lockdown and the planning of exit strategies. Professor Woolhouse, you've mentioned in your report that one of the most important things to consider in respect of countermeasures is that they are both proportionate and sustainable. Could you explain to His Lordship what you mean by sustainable in this context?
In this context, I think a fair description would be tolerable, something that society can live with. I think one way to put it is an option for any government in the world faced with the situation that the UK government was faced with in March 2020 is to declare a lockdown immediately and indefinitely. And I have actually heard that strategy recommended by some people who are particularly keen on the precautionary principle, should we say. No country in the world did that. No country in the world could afford to do that, because at that stage we did not know what the exit from lockdown would look like. The prospect was, that's what came to pass, is there would be a vaccine would be developed that would at least make the public health situation less dire than it was. But at the time, no human vaccine, I'm quoting from Sinetra's area of expertise here, but it had been developed from scratch in less than 4 years. So this was quite a shot in the dark in how long this would take. I personally didn't find anyone that I spoke to at the time who thought it would happen in less than 1 year, although it did by a month or two. But it was that sort of duration. And there is no possibility of locking down for 4 years, and even 1 year is difficult. So you have to have a strategy that allows you to exit from the lockdown, simply to keep society functioning. We discussed already that the lockdown cannot be total anyway, because society has to function, and that in the UK, in fact, millions of people did go about a lot of their business during the lockdown because they had to. So that's the issue. And when you accept that at some point the lockdown is not sustainable, that it has to end, whether you think that's in days, weeks or months, then the issue we were talking about before lunch of timing comes into it. Well, in that case, what exactly is the right time to do it? And one of the reasons for that, and again, I think my colleagues alluded to this earlier, I think Sinetra and David both mentioned it, is that lockdown was never going to solve the problem. The problem was a public health emergency, an infectious disease spreading through the population. Lockdown was never going to solve that. It would defer it, delay it, and for that limited period, how long it was in place, reduce the levels of transmission, but it would not solve the problem. The moment you came out of lockdown, then infections would have the possibility of spreading again. So that's not sustainable. And what I was saying in discussion with colleagues at advisory groups at that time is if we go this lockdown route, what we'll do is we'll go into lockdown, come out of it, go into it, come out of it, go into it, come out of it, for a prolonged period, which is actually exactly what happened. Although, I have to say, technically, for slightly different reasons than the ones I was anticipating at the time. But nonetheless, that is what happened. So that was a realistic prospect. So what bothered me about the public discussions about the March 2020 lockdown was the very strong indication we were getting, particularly from the politicians to the public, that this would be a time-limited measure. That this was a really difficult step, but if we all unified, we knuckled down, we got on with it, and we locked down and stopped transmission, The implication was very clear at the time. The problem would be solved. That would be it. We're having to do this extraordinary step for an extraordinary reason, but it was going to last, and the source of time periods talked about was 6 weeks, 12 weeks. And this was never, ever epidemiologically plausible. That was not going to be the case, and yet it was the message that was coming across at the time. And clearly, it's a lot easier to accept a six-week lockdown that solves the problem, eliminates the virus, as we were talking about before, and then we go about our business, rather than having this as something that's actually going to recur again and again and again, which it did, for at least as long as it takes to not only get a vaccine, but also to roll it out. Not sustainable.
Professor Gupta, do you have any views on whether the non-pharmaceutical interventions were sustainable?
I have to concur with Professor Woolhouse that they are not sustainable on various axes. First of all, of course, the damage they cause is extremely. The magnitude is great, and it is it exacerbates inequalities in ways that are truly unacceptable, not just within a country but across globally. It really is. The costs are just too high, and that's just a very simple answer. But also, speaking from an international perspective, there are countries where you cannot have lockdown at all. There are also countries where you not only can you not have lockdown, it's incredibly hard to implement what we suggested might be an alternative, which is a time called focused protection, but I prefer now to think of it as individual risk reduction. And we must be very careful when we make any recommendation to consider whether a nation is in a place to put those measures in place without causing enormous harm. So what I'm saying is that there are countries which can perhaps have short periods of lockdown or bring in focused protection in full force because they have the means to offset the costs, at least in the short term. So obviously furlough, etc., were efforts made in that direction. But these are not sustainable. Not in the, they are borrowing against the future, essentially. So the costs of NPIs are staggeringly high, and to the point where they are actually impossible to implement in many parts of the world. And then, of course, there's, I guess it's a slightly separate question, but on the what do they actually achieve? We really have to pay more attention to whether, given that we've all agreed that complete, total lockdown is really very difficult to implement, and we've only seen very few instances of it, and those have been very serious, have involved very serious infringements of any form of civil liberty. But given that society has to function, and that we can't implement total lockdown, we then really have to go back to that question of how much lockdown, what is the functional relationship between level of lockdown and interruption of transmission? And unless that is at least linear, one has to be very cautious.
Thank you. Professor Heyman, I'd be interested to hear if you've got any views on sustainability, but in particular, in your report, you make mention of potentially the use of potentially more targeted, what might be termed lockdowns, and in terms of use of measures such as travel restrictions or school closures, depending on what data was emerging. Would you be a proponent, or were you a proponent of more regionalised or localised lockdowns, depending on rates of transmission?
I think first to talk about sustainability, I spoke earlier about, in my view, lockdowns are a temporary measure leading to some type of final solution. That final solution to me is the exit strategy. It's transferring the responsibility to communities where they can do better job at contact tracing than can a centralized function. Communities in general, whether it's a physical community or a group of individuals who make up a community, can do the best possible job on sustaining efforts to contain an outbreak or to deal with an outbreak. And that includes contact tracing. As more interventions become available, they can play even more of a role in sustaining a response to a pandemic. And I'm thinking in particular of self-testing. Once self-testing was available, it was a valuable tool that people could use in communities to determine whether or not they wanted to put others at risk or not by using self-testing and trying to protect others. So lockdowns were never meant to be sustainable in my view. They were meant for a point in time, and then they were to exit into something which would sustain the outbreak or pandemic response, which in my view should have been in communities rather than a centralized contact tracing. It should be localized where there's trust that people who get their information will deal with it properly.
Professor Bambra, in the context we're discussing at the moment in terms of a sustainable non-pharmaceutical interventions, to what extent do you consider that government should have regard to and mitigate for pre-existing structural and institutional inequalities in society and the potential disproportionate impact on vulnerable groups when imposing non-pharmaceutical interventions such as a lockdown?
Okay, thank you. Yeah, shall we just clarify that lockdown, we've had different definitions of it, and that non-pharmaceutical interventions are quite different. So travel restrictions, are, depending on whether they're internal or just around the borders, would have different impacts than the stay-at-home order. So if we talk about more sort of the lockdown as it happened for us in the United Kingdom and Scotland, then there were obviously quite serious implications around inequalities, many negative, though not all, because, for example, because there was an uplift given around universal credit, you actually get a slight reduction in poverty during 2020-21 fiscal year, which unfortunately poverty then goes up again once the extra uplift of £20 a week is taken off. So those mitigation, the economic mitigation strategies looked like they were potentially working to the extent of people who were covered. But if we look, obviously, there were harms, particularly to certain groups, as we talked about earlier, and it didn't seem to me that there were mitigations put in place, nor advice and input sought around what they might be. So we've alluded to the lack of thoughts around inequalities in the planning documents, a lack of inequalities impact assessments going into particular decisions and advice, lack of thought from that regard in terms of how different communities might be able to respond or even understand some of the communications, depending on language and reading abilities and so on. So I think there is a case that you should be trying to ensure that people are supported through that. I'll give an example of, for example, social workers only being allowed to go in and to help children on their lists when they thought it was like an emergency situation. Similarly, domestic violence charities and abuse charities at the time were saying, what about women being, in effect, trapped in the home with their abuser for long periods of time? So there were things there. And then obviously issues around caring responsibilities, children in split homes, that again goes back to the lack of planning in terms of thinking about how would you cope with all these different heterogeneities, if we want to put it in those terms, within the population.
Thank you.
Can I
Yes.
just ask you if you want to also to discuss another group that was disadvantaged greatly by lockdowns, and that's patients and healthcare users.
Yes.
That was particularly striking, and there's a lot of very detailed studies done of that in Scotland, because we have particularly good data on healthcare usage here, and some of my colleagues at the University of Edinburgh and elsewhere were doing some detailed work on this. Access to the healthcare services fell off a cliff in late March 2020. That's planned operations, routine admissions, even emergency admissions fell by 40%. Now, the rationale for this was that the patients had been told we needed to, quotes, protect the NHS. The implication was clear that they shouldn't bother the NHS, that the NHS was doing presumably more important things in looking after the COVID patients. The effects of that were dire. Across the UK, there were an uplift of several thousand people who died at home, higher than you would normally expect during that period. Clearly, those people should have been in hospital, and clearly many people who were very ill but didn't die also should have been in hospital. They weren't. And where this gets particularly distressing is that we have in the UK very good data on bed occupancy in the NHS by our hospital system. During that first wave in COVID, the bed occupancy was at an all-time record low by some substantial margin. We were shown on the TV the hospitals that were genuinely overwhelmed with COVID patients and were struggling to cope. But they were a very, very small minority of actual real hospitals, and usually those situations did not last long. There were some that were very severely affected for a long time in London, but they were a small minority. The hospitals were as quiet, on a national level, the hospitals were quieter than they'd ever been. So we'd completely overcompensated. So people who needed healthcare were not getting access to it. And I met with a group of infectious disease clinicians at the Western General Hospital almost exactly a year ago. And I asked them, did we succeed in protecting the NHS, which was what we were told to do? And their answer was very interesting. It was an emphatic no. And the reason was, it was no because they hadn't been able to deliver healthcare to the people who needed it at the time. So lockdown did not achieve that.
Just to add on to the longer-term knock-on effects, cancer diagnosis, waiting lists. I mean, it wasn't that what happened in that period was horrific, but, that there are very serious long-term effects, which are not unanticipated, I would say.
Indeed, there were studies published in the first half of 2020 that did anticipate them, but they didn't get a lot of publicity at the time.
With that in mind, and in terms of considering which measures that might have been put in place in terms of a strategic approach, how does one determine, or how should one determine, whether any particular measures are proportionate and sustainable?
We're coming right back to the very beginning of our conversation, aren't we, to where we said we need evidence on how this is going to unfold in the very early stages. But I can give you some examples of where we did not use that evidence. So in February, a very large study was published from China on the spread of COVID through close contact between people. They surveyed, I think it was about 7,000 different contacts. Of those contacts that caused an infection, 2 happened outdoors. This was never a virus that transmits well in an outdoor environment. It requires enclosed, still spaces, away from wind, away from sunlight. It doesn't do well at all in outdoor situations. And yet we stopped people going outdoors. We were not allowed to go out except for an hour a day for our exercise. That was a completely unnecessary one based on evidence we had before we went into lockdown. So that's the sort of thing. And I could make the same case, although it's more contentious, but for schools. But for schools, the evidence was that children are not at risk and schools are not playing a dominant role in transmitting the virus, unlike some other infections where they do, but they weren't in this, by certainly April and May 2020, and yet our schools stayed closed. So you've got to respond to the evidence, and we didn't.
Professor Heyman, you say that the location and duration of non-pharmaceutical interventions that suppress individual freedom and are used to control a pandemic must be continuously assessed. What steps should be taken?
There are several steps to take. The first is to start a healthy research program early on in the pandemic, which was done in Scotland. It was done in the UK as a whole. And that program began to bring in evidence very early on. But the studies were designed for longer-term outputs rather than the shorter term, and they weren't examined possibly as much as they could have been early on as they were being done. So there was evidence being collected within the UK. It was a long-term goal, up to 12 months, but there was evidence accruing which could regularly be reviewed. At the same time, there was much evidence coming from pre-publications from China, for example, on the transmissibility, from Singapore, on the fact that there was asymptomatic transmission early on in the pandemic, a whole series of things that should have been taken into account as strategies were examined and as the lockdown was reevaluated. These did not appear to be done early on in the pandemic, and as a result, lockdowns continued as the blunt tool to be reinstigated or reinstalled again should there be an increase in virus after they were once stopped. So they were a blunt tool that continued to be used rather than the tools which had shown to be effective in many different parts, including in studies here in the UK.
Do you feel that there was sufficient re-evaluation being undertaken once steps have been put in place?
I can't say because I wasn't a part of the SAGE or that group. I think it would be best to ask Mark that question.
I just say no then.
What further re-evaluation do you think should have been done?
Well, those examples I gave you are perfectly good ones. It's acting on the evidence. And as David said, we can get the evidence. We didn't act on it.
Professor Woolhouse, you've discussed in your reports not just sustainability, but the question of exit strategies from any steps that are taken. What were the exit strategies, I suppose, is my first question, if any, and do you feel that those were appropriate?
So in Scotland, the exit strategy was very explicitly to come out of lockdown as slowly and as cautiously as you possibly could. That was very clear, and that happened both with the March 2020 lockdown and the January 2021 lockdown. Very, very slow exits, which is the reason, for example, why schools stayed closed during both lockdowns for as long as they did. The feeling was that that slow exit was better. It was even slower in the January lockdown because the authorities, let's call them that, seemed to determine that coming out of lockdown too soon in the first lockdown was the reason why we got subsequent waves. And that's not right. What the situation is, we've been to the R number before, is what you don't want is for the R number to rise, and there's all sorts of things that will suppress the R number, and not all of them are under the control of governments. But you don't want that to rise. But the measures such as closing schools, which we now have good evidence you could do without raising the R number above 1, we could do the next day, and it wouldn't happen. So, but we didn't do that. We thought that very, very slowly coming out of lockdown would somehow suppress the virus in a way that it wouldn't. So I think that was the exit strategy that was used. What it should have been is to weigh the evidence and say, right, will doing this, such an opening schools is a perfect example, will opening schools increase the R number above 1? No, it won't. We can do it now. But we didn't do that.
Professor, you predicated that answer by saying the feeling was. Now that implies to me that you're not aware of any evidence that these decisions were based upon. Is that a correct inference on my part?
Sorry, the feeling was that the schools wouldn't? Or
No. The very beginning of your answer,
Yep.
you said you were answering a question about exit strategy, and you said the feeling was that the slower there was done, and so forth. And I made the inference that the use of the language feeling was implied you weren't aware, you personally weren't aware of any evidence that lay behind such a decision. Is my inference correct?
It is. I can illustrate the thinking with an analogy. So R number, R greater than 1 is a tipping point. So imagine that you're standing at one end of a seesaw. And the Scottish strategy seemed to be that if you walk, you're just you, no one else is on the seesaw, you walk slowly enough along the seesaw up to the tipping point. But if you go slowly enough, you can keep going. And keep going and keep going, and somehow it won't tip. It will tip. But the corollary of that is you didn't have to go very slowly up the first part of the seesaw. You could have got all the way to the tipping point, and it wouldn't have tipped. But no, we thought, we collectively, the Scottish authorities, that if you went slowly enough, the seesaw wouldn't tip. But it would.
Okay, I follow.
Professor Bambra, with respect to exiting lockdowns, you indicate in your response that when lockdowns are lifted, this needs to be gradual and to reflect real-world pandemic evolution and the nature of disease, e.g. how transmissible the disease is and is it airborne, etc. There also needs to be a better appreciation of the social, economic and health trade-offs of lockdowns and inequalities in these. From an equalities perspective, do you have any view, in particular on what Professor Woolhouse has been saying regarding the speed and how lockdown should be exited?
I'm not going to comment on like how quickly it should be or how long it should be, because that's not within my expertise. But I've alluded to some of the inequalities that were happening. Others that were talked about, for example, around healthcare, people not utilising healthcare when they had a health need and dying at home and so on. That's also socially stratified. We know from a lot of healthcare studies, both pre, post pandemic, that people from lower educational backgrounds, lower income community to ethnic minority communities are less likely to seek healthcare until it's later in their illness anyway, in normal conditions, and therefore much more likely to be in that situation than in a pandemic. So lockdown has this negative impact particularly on these groups. So from that point of view, you could say, well, getting out of it as quickly as possible would potentially have a beneficial effect. But as I said in my first answer around the rights, you then have to trade off who was then most vulnerable to mortality and morbidity from the pandemic. So I don't think from an equalities perspective it's an entirely straightforward question to answer, because there's a lot of inequalities in play no matter what happens sort of scenario. However, that said, we could have mitigated better during lockdown once you've made that decision, whether that was the correct thing to do epidemiologically or not, in terms of how you do then support people. I gave a positive example around the poverty reduction through universal credit. Professor Gupta mentioned the furlough and things like that. There could have been other things, again, in an evolving situation. It's not just the disease that's evolving and our knowledge of that that's evolving, but our knowledge of what's going on for people during lockdown is going on and how that's stratified. Also, it has to be said that some parts of the country, I'm speaking more for England now, but I think it's still relevant, kind of almost never got out of lockdown in terms of that tiers situation that was brought in. So the north of England was in the highest tier restriction pretty much for the whole of, post sort of September, October 2020 all the way through. And you can see when you look at studies, for example, of mental health, you have a worse mental health impact in those regions than in the rest of England. And it's sustained longer. You don't get a sort of bounce back to normal levels. And then we can tie that down the road to some of the issues that we're facing today when we're looking at mental health as a reason for young people being out of work. So, some of that will be pandemic related in my view.
Thank you. Professor Gupta?
Yes, I mean, just to say that the effects of lockdown were disproportionately felt by the poor in many ways, including education, of course. So keeping your children out of school for 3 weeks, if you can afford to actually educate them yourselves, or have access to various through the internet to educational programs or whatever, and have a garden for them to play in, is very different to the child who gets his or her only meal of the day at school. Mm-hmm. So we know that there were inequalities. But the other thing to remember is that in terms of the duration and exit, I mean, I'm speaking as someone who doesn't think we needed to go into lockdown at all, mostly, but if you were thinking of the duration of a short lockdown, to remember again that these effects are not linear. So not going to school for something that what Claire just said about the mental health situation in these parts of the country which were locked down for much longer periods. There are tipping points, I imagine. So I think that would be worth keeping in mind, that, locking down for 2 weeks is, well, certainly for someone who lives in a nice house and has a dog to take for walks and, whose parents read Shakespeare to them in the evenings, is not, 2 weeks is not a big deal, but to not eat a proper meal for 2 weeks for a child, it really is. And similarly, mental health, I mean, the first lockdown, I remember my daughters came home, I don't think it had the same kind of effect on younger people as it did when we started locking them in their college rooms. So there are actually thresholds that perhaps one ought to investigate very carefully about just how much. I mean, resilience is not, again, it's not a linear thing. There will come a point where the damage is done, and then often it's irreversible. There is some sort of post-trauma disorder that sets in. So I think some more research on that would be helpful for situations where, we may have to lock down, even if we didn't have to this time. There may be situations where we do, or where, indeed, we've already discussed judicious surgical use of lockdown may be necessary, but it would be worthwhile, given that we've done this experiment, to really collect some data on whether there are these tipping points that we really mustn't cross.
Thank you. Professor Woolhouse, you mentioned the messaging that was coming out of government at the time in terms of the, for want of a better word, justification for lockdown. You mentioned, I paraphrased, the misstatement in terms of the risk levels to different groups of people. Do you have any comment on the messaging that was coming out of government at the time to the public, and indeed the importance of that?
So on the latter part, the importance is absolutely fundamental to the pandemic response, because the nature of this infection, which David's described in great detail, how it's transmitted, who it's transmitted between, in what circumstances, is basically people going around their normal lives. It spreads just as people do what people normally do. So to change that, by whatever means, people have to change their behaviour. That's the ultimate outcome of any action that will reduce the transmission rate. It's all about how people behave. And that includes whether they choose to wear masks or even later on get vaccinated. It's all about what people choose to do. So it's absolutely crucial. The underlying assumption during the COVID pandemic by a lot of advisors and analysts was that the main driver of behavioural change, in fact in some models, the prediction is the only driver of people's behavioural change is government intervention, government diktat. So if they tell us to stay at home, if they tell us to work from home, if they tell us not to go to school or whatever, that's the only thing that will change behaviours. It's manifestly not true that that is the only way people change behaviours. And I said earlier that I was quite convinced now by the evidence that the lockdown itself was not necessary. And one of the pieces of evidence for that is this monitoring system called Google Mobility, which is it's based on Google phones. It's anonymized data, so it's general data from a region, and it just records where people are. It doesn't say exactly what they're doing, but where they are. And you can see in the week before the lockdown in Scotland and the rest of the UK is that there was a major change in people's behaviour. And basically what they were doing is they were spending more time in residential areas, i.e. at home, not going to city centres, not using transit. Their behaviour had changed. Then lockdown came along. So you look at the Google mobility data to see, well, no, did lockdown change the behaviour even more? No, not at all. Flatline. And there's also epidemiological evidence published by the Scottish Government, actually, that shows exactly the same thing in terms of the numbers of cases as well, the transmission rate of the virus. So people had already changed their behaviour in ways that reduced the spread of the virus before the lockdown was implemented, and that they actually had done enough. Now, that wasn't... There were two reasons for that. One, we've discussed this earlier, that there was a lot of advice coming out of government before that about working from home and so on, but also because people were changing the behaviour because they thought that was the right thing to do. Can I just finish one point? And it works at the other end of the lockdown as well. So we talked about exiting lockdown. So there was a great reluctance in the advisory community to recommend the leaving of lockdown because they thought that the seesaw would cross that tipping point, that people's behaviour would change so that the R number would go on and we'd have another big wave. Now, on a couple of occasions, I won't go into details, but that was forecast, predicted quite clearly by the advisors, and it didn't happen. And with a little bit of hindsight, you can see why. The models said, we release the restrictions and people immediately rebound to pre-pandemic behaviours. They behave as if this had never happened. No, they didn't. They, and they're wise here, they were a bit like Scottish Government. They exited very slowly and cautiously. Their behaviour changed slowly and cautiously. And so the impact of the releasing restrictions was not nearly what the models had predicted. So it's people changing their own behaviour that actually, well, they are the driving force for what happens to the pandemic. And they do that in line with what government's telling them to do or not to do, but they actually make their own decisions about it. And pretty much they're quite sensible about it. Thank you.
Yeah, thanks. I just wondered how much of that change of behaviour measured in the way it was with Google Mobility is also reflecting anticipation of a lockdown, because not only had the UK government seen all the TV footage coming out of northern Italy, but our own public had too. The possibility of lockdown was being openly discussed in the media and so on. So I think I agree that there was a sort of self-regulation to some extent, but some of it I think was because there was an anticipation that it might happen. And one kind of aspect of that is that, again, it's easier to adapt and work from home if you're voluntarily, if your employer is able to function in that way, if you've got a white-collar professional job versus, if you are going in to clean the hospital, to use our earlier example. So I'm not sure everyone would have benefited from being able to undertake those behaviours. Voluntary behaviours are easier to undertake when you have more autonomy and control through your in effect, your economic or educational position. So I just wanted to add that in, really. Yeah.
Professor Woolhouse, you mentioned the fact that you felt some of the messaging, my word not yours, was false or erroneous in certain aspects. Do you consider that had any impact in terms of either people's behaviour or the response more generally?
So this touches on an active area of debate within the public health community, which is this. Is it appropriate to use fear to drive the public health response? I think I'm going to have to lead that to my lordship to ultimately adjudicate on that. But that's what was done. So I don't know how much detail you want me to go into this, but I'll give you one of the consequences of the, I won't call it misinformation, I'll just say the information emanating from government and from many sources of the media during the pandemic. And this is one of the consequences that's been researched quite a lot. If you ask young people, so school children, university student age, to assess their own personal risk of COVID-19, of getting COVID-19, we've got quite a lot of young people here, I don't know what your answer would be to this, but if you're typical, you will overestimate your personal risk by something like 100 to 1,000 times from the studies. Because we were told the virus does not discriminate. Everyone's at risk. And they believed them. But it wasn't true. And this is and ironically, one of the things is in an epidemiology class in America, these are people who should understand this, but they don't. They overestimate their risk by that amount. So that's the consequence of, let's call it mismessaging, to be diplomatic.
You may not know, but if you have a view, I'll ask it you. Do you think that the government messaging increased the level of fear in the public?
It was designed to do so. So there is the notorious quote from the SAGE subcommittee, SPY B, behaviour, where they issued advice that I can't remember the exact quote, but they felt that too many people were not sufficiently alarmed by COVID-19 because they perceived their personal risk to be low, my brackets, which for many of them it was, so that the government should ramp up messaging using powerful emotional images, hence the things on the side of the bus, do you want to do this to your grandmother? You remember with in hospital with the breathing tubes out, as if a child, by going to school, could do that. And that was the messaging. And so it was designed to raise the alarm, induce fear in the people. And I personally have trouble with that as a way of implementing a public health goal. My personal view is that people make good decisions when they have good information. It all comes back to situational awareness, and that's particularly, that applies to individuals as well as it does to institutions. If we know the risks, and we can manage our lives as we see fit. And just to finish off one last point, something David mentioned earlier, which is very important about the self-testing, which we were extraordinarily slow to roll out here in the UK. It took over a year before the self-testing was successfully trialled in Liverpool, but before it was rolled out to make it available to all of us. That allows people to establish their status and change their behaviour accordingly. It empowers them to manage the risk to themselves and the people around them. And my view is that the people were very, very good at doing that if they had the right information and the right data. But they weren't getting it through we are all at risk and the rest of it at all.
Thank you.
They were being misinformed.
I'll come to Professor Gupta first and then Professor Bamborough, if I may.
I just wanted to add to this business of telling people they were individually responsible for the deaths, which I consider to be a dereliction of a particular duty we have in society, particularly towards young people, which is to disperse the guilt of transmission. Because, people die of infectious diseases and someone will have given them the disease. And what we undertake to do as a society is to disperse that guilt, not to say, well, you killed your grandmother. We say, this flu exists, flu circulates, your grandmother died of flu, if anything, we say you must not blame yourself. And we did the opposite of that. We individualized guilt in a way that I think was extremely harmful to the younger generation. I think they really lived in fear of being responsible, because it's a huge responsibility, which is why it has to be taken away and shouldered by all of us. And instead we put that responsibility onto young people. I think that was unconscionable.
Professor Bamber?
Thanks. I just wanted to come back to the sort of being able to make the right decision if you have the right evidence, or, you know, good decisions and good information. Because I think you can, it kind of refers to my earlier point, you can do that if you're in good condition. So, you know, we might all be able to interpret, you know, being told that our relative risk is X, or we're 1,000 times less likely to get it than someone else, and then interpret the relative and the absolute. But I don't think that plays out for a lot of people in the real world to know that. So I don't think everyone can make whatever the right decision is, and we're not even sure around this table what the right decisions necessarily always would be in any circumstance. So we have to bear those constraints in mind when it comes to a more sort of self-regulated approach. And there would need to be government guidance and messaging for specific groups. As you do get advice, you know, when looking over the planning documents, when talking about, you know, additional advice should be given when you're planning for flu for pregnant women, for example. So you need to expand that. It can't just be that we can all interpret the data on our own.
I'd like to ask something to all of you, really, arising out of this last batch of questions. We had evidence last week from a Swedish epidemiologist. He was, in fact, the state epidemiologist at part of the pandemic. I hope I'm not going to misrepresent his evidence, and I apologise if I do. But he gave evidence, the general tenor of which was that, as I think you're probably all aware, while there were restrictions in Sweden, it's not correct to say they had no restrictions. On the whole, they were less severe than the restrictions in the United Kingdom. But he also gave evidence that, notwithstanding the relative lack of severity in the regulations, the population, by and large, followed what I think he called something like common sense, and followed the sort of general regulations that I think Professor Woolhouse has been talking about. Now, he offered, I think not with enormous force, or intending to have much force, he said that, you know, Swedish people tend to follow advice, follow regulations, and I don't want to get into a cultural discussion because that's, I think, beyond any of our knowledge. But he also said, which I thought was very interesting, that there is, and I hope I'm correct in this, there is a statutory obligation in Sweden upon public authorities to be frank and transparent, and indeed to put all relevant knowledge before the public before they impose any form of restriction or make any advice in relation to restrictions. If there were such an obligation in British, UK, Scottish law, imposing, when it comes to considerations like putting relevant scientific information before public in an emergency situation, would you consider that to be a good thing? Well, let's start with Professor Hayman, but we'll go around the table.
Yeah, thanks. I was going to reference, I was going to reference the Swedish, because during the pandemic there were a series of discussions at Chatham House, and Sweden participated in those discussions. And one of the things that they said at that time, and I'm sure they mentioned here, was that their communication strategy had been right, but that it was in the wrong language for many of the people who were working in care homes and other places because they didn't speak the Swedish language. And so they realized this early on, and they changed to English for many of these. But communication is very vital in this, and they put that out as truth. They also said that trust was very important in their government. And it is important, and what's even more important is that those who are the face of the epidemic or pandemic not only tell what should be done and what they know, but what they don't know. Because if the population understands what's not known, they can then anticipate that information will eventually become available. So this was thought to be very important in Sweden, I'm sure in other countries, that it's not only important to communicate what is known, but to communicate what is not known and what might be known in the future. Second, it was very confusing during the pandemic in many countries because of all what I like to call the armchair epidemiologists, those people who really didn't have experience in the field or in public health, who were standing up and making recommendations based on what they felt was important, and many times they grabbed the headlines. And the third thing is that it was really, in many instances, too easy for the journalists to get a headline and to get an article if they had a panic driving headline. I myself was very active in interviewing early on in the pandemic, but all of a sudden it changed to the fact that instead of asking, the journalists were telling me that this was a very important issue to discuss, and they had already decided on what they wanted to speak about many times in order to get their article published. So I think it's not only the communication from the government that's very important, but also from others within the countries, academia and the press, journalists.
Professor Gupta?
I completely agree that the public should not be patronised by telling them they don't know what's going on, and only, somehow that's the preserve of academics and politicians, and the press behaved very poorly, I think. But just going back to this, issue of spontaneous or voluntary behaviour change, and people will do the right thing, sensible thing. Of course, I agree with Professor Woolhouse and Dr. Tegnell that that Sweden and indeed in the UK as well, people were behaving, perhaps spontaneously reducing some of the their behaviours that would cause further transmission. But I also very strongly agree with Professor Bamborough that, yeah, if you could work at home, it's fine. But what if you can't? What if you have to go out? And I think to earn a living, etc. I think therefore
I think we're ready to start again. Thank you. Mr. Turner?
Professor Gupta, we're back to you. Hopefully
to
you've not
me.
lost your
Where
train of thought.
I've been holding it in my hand.
You were just agreeing with Professor Bambra, I think. We'll take it from there.
Okay. Yes. So I think that while voluntary behaviour change could have played a role in the dynamics, I think, the dynamics can also equally be explained by seasonality and other factors. I think that whatever might explain the dynamics, a strategy needs to be robust to behaviour change, because voluntary behaviour change, because we don't know whether people will behave as we would like them to or think is the right thing. And more importantly, as Professor Bambra points out, they may not have the ability to put those changes into practice if that means, for example, losing income.
Professor Wilson?
I thought your Lordship's suggestion was actually very interesting. I think it will be resisted on two fronts. One is by the category I mentioned earlier of those who think using fear is a legitimate public health tool. But the other, a larger group in my experience among advisors, who are accepting of the noble lie. That even if the threat to certain subgroups is exaggerated, there is a greater good that comes out of implementing a lockdown or something. So I think it's an interesting suggestion, but it might get resisted. I should move
Really
as far as I
my question.
Sorry?
Was it a good suggestion? I said, perhaps I shouldn't care whether it's resisted or not.
I think I'm sorry. I'm a pragmatist. It's a good suggestion if it can be delivered. That's it. I will move as far as I can in Claire's direction, which isn't quite all the way. But I think for people to make the good decisions we're talking about, they need to be provided with the information. I absolutely agree, of course, that the messaging should be tailored to what people can absorb and understand. Yeah. We shouldn't be talking in terms of R numbers and things like that for trying to enable people to manage their own risk, which is what we're talking about. And I also strongly agree, both of you suggested this, Sinetra and Claire, that people should be enabled to act on that information. That is the second big barrier. The first big barrier is they don't have the right information in the first place. The second, as you quite rightly say, is that significant parts of the population are not easily able to act on that information. So they have to be enabled to do so. But this is now a different strategy by government. This is, and this is the strategy I would like to see, which is a strategy where government is helping people to manage the risk of this pandemic, not imposing on them, not forcing them, not giving them misleading information, but helping them manage the risk themselves.
Interestingly, and again I hope I'm correct, Dr. Tegnell used the language, which I'm sure you're all familiar with, of, as we would be comfortable with, of informed consent, that people should be given enough information, accurate information, to enable them to make an informed decision. And of course that raises issues along the lines of Professor Bambra has been raising. But are you comfortable with the language of informed consent?
Yes, I saw that contribution. I'm on the fence on that one. Informed consent has got a definite meaning in health and science. And I think this might be stretching it a little bit, but I see what he was getting at.
Yeah. Okay. Yes, Professor Bambra.
Thank you. I just wanted to come back on this behaviour change element around people having knowledge to manage their own risk, as it was something we might come back to with some of the other things in the running order, and the kind of talk we have about individuals rather than about populations and communities and ultimately, geographical areas. So it's not just about managing my own risk. There is an element to what are the risks of the people around you, particularly obviously the people you're in a house with. And that's where some of the I'll say systemic differences between the UK and Sweden matter. I won't go on to cultural, but systemic. So I'm talking, for example, about the ability to self-isolate if you're infected and not go to work. And as you may recall, there was concerns over basically the value of statutory sick pay in this country being extremely low. In Sweden, the payments are much higher as a proportion of people's income. So in other words, it is easier from a financial perspective to self-isolate in one of the Nordic countries than it would have been in the UK from that kind of self-regulation. So there are things that we would need to do to sort of fix aspects of our society whereby we went into the pandemic not just unprepared for this type of virus or unprepared for what we did or the impacts of what we did, but also kind of systemically unprepared to have the things in place, be it a healthy population or be it the system to support people, whether it's, you know, being ill from COVID-19 or being ill because you're injured at work or some other illness. We're not set up for that from a public health perspective. And all of these things would matter in order for us to be able to take a more self-regulatory approach, in my opinion.
Thank you, my Lord. Can I just check, just prior to His Lordship's question, Professor Heyman and Professor Gupta both had indicated to me they had something to say. I didn't know whether they had covered off whatever points they had. Thank you. Professor Heyman, perhaps I could ask you, with this question of instilling fear or misinformation, and I suppose I'm mindful of recent comments from compatriots of yours in terms of scepticism over various medical matters. But does trust in the message matter? And does it have any real-world effects in terms of people's behaviour?
Trust does matter, and I think a good example of how it matters is the rapidity with which the United Kingdom was able to vaccinate its populations because they trusted the messaging that came from the NHS. Other countries struggled in many instances to gain that confidence. So I think trust in the health system is extremely important in the way the population responds. Misinformation is very, very difficult to deal with, and it's becoming more and more important, especially in the country that I know very well. And it's going to be very difficult in the future to deal with that misinformation unless the government takes a strong stand against it.
Thank you.
Can I just comment on a study that was done in America by a team from Harvard University, who I won't name? They did a study on whether people with hindsight in America agreed with the restrictions that were placed on the society, one of them being the closing of schools. And the study reported, its headline was, "A majority of Americans agree that these were the right things to do." Turned out within that study there was a significant minority who actually understood the risks of this. And the significant minority that had a good impression of the risks didn't agree with closing schools. So the agreement of the American public depended on their misunderstanding the risks to children. Well, I don't think that's a version of the noble lie, and I don't think it's acceptable myself.
Yes?
I just wanted to return to His Lordship's point about having the knowledge and why decisions being made and some of the uncertainties put out in public in this wider context. I think it is a very good idea, because we now are in a position of having to restore trust, I think, after some of the issues that we had with behaviour of politicians during lockdown and how that eroded, in my opinion, public trust. But if we don't put information out, and all of us in academia are required to do open science in terms of our research, you don't just publish the paper these days, you're encouraged to also publish the data set upon which it was based so that other scientists can check your calculations. That's become usual practice. So why not do it when, in a sense, it really matters, right, in a public health emergency? And my view is that if we don't, then we now have, that vacuum, in a sense, will be filled, as it is at the moment, with social media, with declining rates of vaccine uptake, even in the United Kingdom, and particularly in more deprived and minoritized communities, partly because of concerns sometimes coming from politicians, sometimes coming purely from social media in terms of the role that vaccines play.
But surely there's also a pragmatic issue here, because David raised the role of trust. If you make a statement such as we're all at equal risk, the virus does not discriminate, many people will work out that that's not true. Now, it may in the short term have some perceived to be positive benefit from this, but in the long term, that can only erase trust, and I think that's been very damaging through this. I think it's kind of a point of principle, but it's pragmatic as well. You cannot retain trust if you're not giving everyone, telling them exactly what the situation is, not sugarcoating it, not exaggerating it, nothing, but tell them the facts as you know them. Anything less is dangerous.
Professor Willis, I have a question here, and it may be, you may feel it's out with your expertise, so if it is, please feel free to tell me. But do you think that better government messaging about the actual risks would have led to better voluntary compliance with non-pharmaceutical interventions?
Well, the study I just quoted from America is an example of the outcome of that. I haven't seen studies of that exact nature done from the UK, so I don't think I can add to my previous answer there.
I'm going to ask you a related question, and your answer may be very similar, but I'll ask it in any event. Do you think that better informed members of the public would be less accepting of enforced restrictions?
Yes. I do, but they wouldn't be less accepting of all restrictions. What we haven't got to this, but maybe we'll get on to it tomorrow. But again, I come back to the thing: the alternative to lockdown is not doing nothing. What we're building up to, I hope, is an idea that the risks were so immensely variable across the population that what is not necessary for one portion of the population is much more necessary. So one of the outcomes I tried so hard to achieve in my various advisory roles, but also through the media during the pandemic, was better protection from this identifiable small subset of the population, 10 or 20%, who were at vastly elevated risk. I tried everything I knew to try and get people to focus simply on that, not argue about strategy, philosophy, ideology, or anything else. There is a small population out there that we know who they are. They badly need protecting better from this virus. And that got completely drowned out by this "we're all at risk, the virus does not discriminate" message, and the blanket restrictions that followed on from that. So if this better understanding of risks did what I would expect it to do, is get people to think, well, no, we should be focusing on these people who are so vulnerable and not on the whole of society, then it definitely would improve our pandemic response. And I think it probably would have done that. But I could not get the message across in 2020, 2021.
Professor Amon.
To follow on to that, the risks are different for different groups. The risk for the group that doesn't become ill from infection is that they could carry it to people who are at risk. Mm-hmm. So one risk message doesn't do for all the population. You have to have different risk messages for different populations. And I think that's what Mark was alluding to, that the messages are there, but it's not the same risk for each group of persons.
Professor Bamber?
Yeah, and I think we could identify some people, and as time goes on, you have more knowledge, who might be able to identify more people who are potentially more vulnerable to it. But I don't think a priori we would have known that people from certain ethnic groups would have the highest case fatality rate, for example. And so I'm not convinced we would have the data and surveillance and knowledge. So, for example, we have a huge gap around our health-related data on ethnic minorities in general. So we would need to do things again in advance in order to facilitate that kind of, in effect, kind of health surveillance to know. And again, that's somewhere where the Nordic countries have better individualised health records linked across to employment records and things like that than we have.
Indeed, and we heard evidence of that last week.
Can I answer that?
Yep.
So of course you're quite right. Our understanding of the risks evolved, although they were pretty well developed within the first 6 months of the pandemic. Here there were studies like the COVID study and so on. So that did evolve, but by far the most consequential heterogeneity in risk with this virus was age, by far. Overwhelmingly. Everything else, they're important, of course they're important, but age dominates. And we knew that long before we went into lockdown. That was established.
Professor Gupta?
No, that's exactly what I was going to say is by February 2020, I think I don't think our, the estimates that we, Mark, that you pulled out for stratification of risk by age have really changed that much since then. No. Obviously, it needs to be refined. For example, we thought maybe asthmatics might be more at risk, and later we realised that wasn't necessarily the case. But they have to be refined. But I completely agree with Mark that, I mean, agreeing not just in the sense of I agree with you that we knew by February 2020 who really was at risk, but just that the proof is in the pudding. Have our estimates changed that much since then?
No, not a great deal. I take it the inquiry is aware that the average age of a COVID death is greater than the average age of death. I mean,
I think
as in the mortality.
We're aware of the age profile, and we have the statistics. I'm not a statistician, and therefore, I'll have that checked. But I think we are aware of that.
Well, I mean, the implication is. For me, that's a very good definition of a disease of old age. The people who were dying of COVID were older than the average age that people die. Yeah. And very few diseases like that. One of them is dementia. But that's not a typical profile, but it was the profile for this disease.
But the other implication is that what we should have done as soon as we saw that age profile is put in place measures to protect those people.
Yes.
Lord, with your indulgence, I have one more question to ask before the break. Professor Gupta, perhaps I could ask you, we've talked there about the fear messaging, the effect that might have on behaviour. Could I ask, what role, if any, do you consider that science, I suppose, advisors and scientific advisors and experts have to play in tackling misinformation during a public health emergency?
Well, as I've already mentioned, I think that it's very important that we do not patronise the public. So the public should be perfectly capable of understanding the complexities of this situation. I mean, it's not, quantum mechanics. It's something that, yes, having a mathematical model or knowing how to do sophisticated immunological assays gives you the correct insights. But what you learn, the learnings, one can communicate to the public, I believe, in a fairly clear way, such that people can see the picture. And in some senses, that is what I've kind of seen as my role since that time, is just to, so many of the public lectures that I've given since then have really just been focused on telling people what herd immunity is, what happens when you have a disease or a virus like SARS-CoV-2 where you don't get complete protection from further infection as soon as upon first infection. What is the stratification of risk of death by age? what happens, how does the risk of disease, severe disease, change with exposure? So one of the crucial features here, and the reason people aren't dying anymore, and I think the reason why people didn't die during the Omicron episode, is that a single infection does not give you immunity to reinfection, but it gives you substantial immunity against severe disease. This is what the vaccine exploits. And this is why our expectations of the vaccine should have been that it does that. Again, judging from what we know about the other coronaviruses. So, and you know, these are things that are not difficult to tell the general public. They can be done without patronising them, and that then sets the stage. Obviously, that's just the science itself, and there's a lot more to be layered onto that. But if you have a fundamental understanding of what you might expect a new virus to do, what the critical features are in terms of disease outcomes and exposure, these are not difficult things to, the concepts. They can be explained, and I think that is our role, is to try and explain these concepts in a way that is accessible.
Thank you. Well, Professor Bamber would just like to come in.
Thanks. I just wanted to obviously note that the age of hospitalisation was much lower than
10 years,
the
younger,
age of death.
70.
Yeah, and then you're looking at the concern over how many ventilators and things we had. So it's not just about who dies, it's also about who gets ill or whether they can be treated. And then obviously the knowledge of the disease did progress, and it's now considered, you know, a multi-organ disease. There's long COVID still within the community, again with big inequalities, on this occasion more prevalent amongst women than amongst men. So there are other factors that would need to be brought into this, is what I would like to point out.
May I have one very short comeback to that, which is that the average age of hospitalisation to COVID is also older than the average age of hospitalisation.
I don't know what are you implying with that, because I sort of take away that the implication is that maybe these people don't matter because they're older, and I hope that that's not what you're saying.
I hope no one around this table got that impression from what I was saying, because it's categorically not the case.
Very good. We'll break now until a little after, just 2 or 3 minutes after the hour. Very good, thank you.
All right.
Thank you, my Lord. Professor Woolhouse, I'm going to move on now very briefly to a question regarding your communication with the Scottish Government. We've spoken at various points today regarding the state of knowledge, your understanding, your predictions, I suppose, at the time, in terms of the likely progression of what ultimately became COVID-19. Could I ask you, what, if anything, did you do, in particular as chair of the infectious disease epidemiology, to raise your professional concerns with the Scottish Government?
I wrote to the then Chief Medical Officer for Scotland.
Thank you. And what was her reaction?
The initial reaction, I first wrote on January the 21st, from memory. And I believe I wrote again on the 24th and 25th of January, because that time I was becoming very, very concerned. And I was worried that I didn't see signs within the Scottish public health community that they were preparing for an event on the scale that I was anticipating by those dates. I got a rather bland response.
You've given evidence both to ourselves and indeed to the UKI in terms of the extensive exchanges that you had with the Chief Medical Officer, so I won't delay us today with that evidence. But if I could just ask you very generally, do you feel that your excuse me, do you feel that your communications were understood and acted upon?
The first one's harder to answer. They weren't acted on in the way that I wanted them to be acted on. There was not a concerted effort to prepare again for an event on the side of COVID in late January here, and not for much of February either. Whether they were understood, I don't think they were believed. And I think there's multiple reasons why the Chief Medical Officer didn't necessarily believe the event would be as severe as I was saying. So, not least, without going into details, that of course she has many other lines of advice than just me, and I don't think those lines of advice were unanimous on the matter.
Thank you. As I say, my Lord, we have extensive evidence on this. Yes. I won't delay matters further. If I could ask you now, I'd like to talk to you about the question of data. We've spoken about questions of surveillance and other matters relating to that, but Professor Heyman, could I ask you, how important is the monitoring of the efficacy of interventions?
It's extremely important to monitor the efficacy of interventions. At first, the efficacy cannot be determined, but certainly an idea of the effectiveness of an intervention, that is, how it's being used and how it's being operated, can be determined. But there are certain interventions for which we have indicators of effectiveness, such as infection prevention and control in hospitals. The UK has a very good system of determining what levels of infection are occurring in health facilities, and that's a very important indicator of how you might see an epidemic or a disease spread within a hospital. So it's very important to monitor, to use the data that's already present, and to collect new data as new interventions are placed into use. A good example would be the self-testing which was used. First of all, you would understand how many people are using it, how the uptake, and then eventually you might be able to tease out from all the different data how effective that has been in stopping transmission, for example, in families where there were elderly people or issues such as that. So constantly being aware of the importance of monitoring what's going on, both the process of how it's been delivered and its effectiveness, and then finally its efficacy is very important.
In your written response, you indicated that surveillance and reporting systems were strengthened within the public healthcare and social care systems. Can you describe what those systems were that were strengthened and explain how they were strengthened?
Systems that were strengthened were on the dashboard that the UK put up and included periodic serological surveys to determine the level of antibody and infection in persons, reporting of serious events and death in hospitals, which was strengthened in its reporting and recorded regularly. But there was a failure to report certain things, such as we heard earlier about social status, and also things such as comorbidities, which were not clearly linked to death as they might have been.
Again, within your written response, you refer to data capture that needs incorporated in surveillance activities. Professor Eamon?
Sir?
You indicate in your written response about data capture needs incorporated in surveillance activities. Could you explain what you mean by that?
Data capture is just making sure that what's known is reported. And so what is known in a hospital as far as the mortality or morbidity of its patients must not only be recorded, but must be captured at different levels in order to feed into better understanding as it's used throughout the country.
Thank you. Professor Bambra, do you feel that the surveillance of health inequalities is sufficient, in particular, to allow for policy making and pandemic response?
Not currently, no. As I mentioned earlier in the response, we do have big data gaps, particularly because our population in the United Kingdom is quite dynamic. And we're very reliant on a census that happens every 10 years, and which, of course, doesn't capture everybody even then. So that's something that's used a lot, for example, with calculating mortality rates for specific ethnic groups, but it's not keeping up. So I alluded to the fact that Nordic countries have better linkage of their data between, for example, hospital records and what would for us be, Department of Work and Pension or HM revenue, so you can get a better sense of people's socioeconomic status, for example, education and so on, but also much better knowledge of their health as well.
Thank you. Professor Woolhouse, excuse me. Professor Woolhouse, we've mentioned questions of modelling, epidemiological modelling. Could you explain the importance of that?
This is a commonly used tool in public health to assess both the evolution of an epidemic, the health burden it will cause, the mortality rates and so on, and also as a first test of what we think collectively that the impact of any given intervention might be. It's a very important tool because infectious disease epidemiology and epidemiological modelling is quite an advanced and sophisticated area of scientific research. It's been around for a best part of 100 years in one form or another. And it allows us to explore options in a way that you could never practically test in the field. You can't clinically trial all the possible interventions that you might make during a pandemic. So it allows you to explore options. The difficulty, I think, comes from my point of view, is, and Sinetra alluded to this earlier, is when people take the outputs of those models too literally. Maybe this isn't quite the right description, but in a way they're thought experiments. They are constructed if you assume that, if this was the circumstance, and you can capture that mathematically. But clearly it's a very simplified representation of a very complex reality. Often, for example, doesn't include lots of the inequalities that Claire studies. It's not there. So I think they are extraordinarily useful and powerful tools for giving you a broad brush impression of what's going to happen. You know, for example, the models I were using, which were as simple as they come, in January 2020, communicating with the Chief Medical Officer, I said earlier that they included scenarios such as an event that would last 2 years and have 3 waves in it, in roughly the right timing as they came, as it happens. But I never, ever badged that as a prediction. We even took the precaution on our graphs of writing, this is not a prediction, this is an illustration. But they're quite powerful illustrations because what I could tell the Chief Medical Officer, even that early, is this is the sort of possibility, the way this event will unfold. Not a precise prediction. We're not going to say there will be this number of cases in the exactly 9 months' time. We can't predict anything like that. But it's the sort of possibility. It keeps coming up when we do this. It's the sort of thing that government should be prepared for. We're confident enough to say, this could happen. So you need to be thinking about that. You need to be thinking about that policy. But there's always been a tendency for people actually to take these predictions more literally than that and treat them as actual solid predictions. For example, that 500,000 people will die if we don't implement severe restrictions immediately. And that is too literal for me. I prefer to use them in a broad brush sense.
Thank you. Professor Gupta, did you have any thoughts or concerns about the modelling that was being used? Or indeed how the modelling was used?
Yes, I mean, just to reiterate almost precisely what Mark said, I mean, models are extremely important, extremely powerful conceptual tools, but they aren't very good at making specific predictions. And there is no contradiction in this. So I became concerned about the way the models were being used, particularly because they have this sort of, I mean, that they have an air of mystery, an air of, the language of modelling has an air of mystery and a hieroglyphic quality to it, which, creates awe. And at the same time, the predictions themselves have an air of certainty to them, which simply doesn't actually exist. So they are very good at creating an illusion of certainty when in situations where there isn't certainty. And this goes across the board. We're not just talking infectious disease modelling. Same in economic. I mean, this is a general problem with the science of modelling. So it is extremely important to understand that models are conceptual tools, very powerful conceptual tools. And I think, frankly, it's a misuse of modelling to tout them as having the features of sort of precise prediction. I do think, I mean, one thing I actually, one of the ways people criticize models is to say, oh, well, it doesn't have this, this, and that in them. It's a simplified version of reality. I actually don't think that models are obligated to have complexity in them. I think that actually takes away from a model. Models, as their name suggests, are something that you substitute for a complex reality that gives you an insight into the reality. I mean, if you think of Newton's laws, they are pretty bizarre in some ways. If you just think, oh gosh, why doesn't this have that? Why doesn't it include that? This and that. That's not the point. The whole point of a model is that with a model, we're trying to do what we do all the time, which is we're limited by our senses in perceiving reality. So we try and substitute something that takes us closer to, if you like, the thing in itself, than what we can see. And that's where mathematical modelling comes in. And it's an extremely powerful tool. As I said, I'm making a flu vaccine now. The idea for it came out of a mathematical model of flu, a very simple mathematical model of flu. So it's not only are they useful conceptually, they have very direct translational effects. But you have to recognize them for what they are, as conceptual tools rather than, soothsayers or crystal balls or whatever, in order to use them correctly for them to actually have a translational impact.
Do you feel that was properly understood during the pandemic, the limitations or purpose, I suppose, of these models?
Well, I mean, first of all, that is my viewpoint. So I think we could say that there is possibly a divergence of perspective on that point, with people who are using models and saying there will be exactly this many deaths, or this is how it's going to play out. And indeed, the fundamental assumptions I keep bringing up, that transmission can be interrupted through incomplete implementation of protocols or measures that can reduce individual risk, but exactly how they translate to population level. All of these are, in order to fully use models to consider the impacts of these NPIs, one would have to acknowledge that, setting up the way in which you encode ideas about how an NPI can affect transmission, the way in which you set up your heterogeneous population is extremely important, and that creating a very large computer simulation in which you throw everything in isn't necessarily the best way to understand how the epidemic will unfold. That's my opinion.
Professor Heyman?
Just to add to these observations with which I agree, models are based on assumptions, and the more accurate those assumptions, the better the model, of course. And what models oftentimes lack is they can't quite use assumptions based on behavior, based on what's known from past outbreaks, although they could if they would look into things like the previous understanding of coronaviruses. And so they lack certain assumptions which can make a difference. And I'll use the example of the Ebola outbreaks in West Africa, which we all remember. The modeling at that time, both in the US and in the UK, was suggesting that there would be a tremendous number of deaths because there were not sufficient hospital beds to take care of the people. And so immediately, foreign development assistance was aimed at developing hospital beds in these countries, whereas eventually what happened was communities became involved, understood the issues, and began to support the activities being done in the communities to stop transmission. And in the case of one country, transmission had stopped before the development aid had completed the hospital beds that they were building. So it can many times mislead if the appropriate assumptions are not added. And as I said, behavior is one of those. And then many times it's a rush to get the assumptions out there without a thorough knowledge of what went on with similar infections in the past. Again, many times models are best or worst case scenarios. And unfortunately, what our political leaders like to take is those worst case rather than the best case scenarios and push them forward.
Professor Woolhouse, you've discussed on a couple of occasions the R number that we've heard banded around. Do you have any comment to make regarding the presentation of the data, in particular the R number or the like, in terms of people's understanding of the progression of the pandemic?
Well, this was a novel development, that in addition to the daily bulletins we were getting on the number of cases and the number of deaths of COVID in the country, we were also getting weekly updates on the R number, which, as an aside, was 2 weeks out of date by the time it was published, because of the nature of the data that it relies on. But this was new. I won't go into the details, but there have been other examples where the R number has been a significant policy tool, but not that it's received the sort of public level of exposure that it got during this pandemic. And what I learned from that is that very few people understood it, including politicians and including decision makers of all kinds were not fully understanding of this. And to give you an example, there was quite a common perception that the aim of the strategy in Scotland during COVID was to reduce the R number to 0. And then one of the most important observations that comes out of the simple general models that Sinead was rightly extolling there is that in order to turn the epidemic curve and reduce the public health burden, you don't need to get the R number to 0. You just actually need to get it down below 1. And that, back in the 1940s, was one of the absolutely fundamental insights that this sort of analysis generated. And that has profound public health implications. You don't have to perfectly isolate every last case. You don't have to quarantine every single individual. It's not R equals 0, it's R less than 1. And that brings back to the proportionality. We're not aiming for perfection here. We don't need to achieve it. And which is why there's, I was suggesting, for example, you could reopen schools. Yes, there might be a slight increase in the R number as a result of doing that. The literature gives a range of values. They actually go from 0 to about 20%. But that's well within the scope of increases that we could accommodate without the actual number going above 1. So this distinction between stopping transmission completely and keeping our number below 1, I think was very poorly understood. And there's a general perception that actually, as a communication tool, for those sorts of reasons, it wasn't really that effective for helping the public understand what was going on. I prefer other measures, which is the flip side of that one, but it's an empirical measure, the doubling rate. But the doubling rate, you can monitor that not just for cases, which is what the R number is concerned with, but also hospitalisations, deaths. You can monitor the trends of the epidemic in a way that the R number simply doesn't do. The other thing the R number doesn't do is it doesn't tell us, any of us, about our individual risk, something we spent most of the day discussing. It says nothing about that. The R number, as a single number, more or less assumes that we're all equal. There are some subtleties there with some of the mathematics, but the way it was used during the pandemic was more or less to that effect. So I was very unconvinced by its sudden rise to prominence as something that we were all told about. And even, I have to say, I can't name names, but a very senior person on one of the committees that I was at renamed it the R monster for that reason. We've created a monster, they said, and now we're obliged to tell government what it is every week. We shouldn't be here. This isn't a place we should have arrived at, and I think that person was very wise in making that comment.
Thank you. Professor Heyman, we've spoken about the assumptions that go into models, and those assumptions are no doubt based on the data that's available at the time. The inquiry has heard evidence regarding the use of randomised controlled trials in assessing the efficacy of non-pharmaceutical interventions. Do you have any comment to make about the appropriateness or necessity of randomised controlled trials in a pandemic situation? And separately, do you have any view as to whether that is the only way or otherwise of assessing the efficacy of non-pharmaceutical interventions?
Clearly, randomized controlled trials are the best way to determine the efficacy of an intervention, or eventually looking at those. But it's very difficult to sort out the impact of one intervention when there are many others being done and implemented at the same time. So if you were to do a randomized controlled trial, you would want one group which does only one intervention and a control group which doesn't do that intervention. That's impossible to do in a pandemic. And so you must look at what the ensemble of interventions are doing, and it's very rare that you could sort out what an individual activity is doing, except by epidemiological modeling, which you can take some of the data from, or from some tests in the laboratory. There was testing of mask efficacy in preventing droplets from passing through. Different activities like that can be done, but an actual randomized control trial would be very difficult to provide information on one specific intervention.
I'll come to you in a moment, yeah. Professor Wilson. If I could just follow that up, Professor Heyman. It may be implicit from what you've just said, but do you consider it's legitimate to therefore consider real-world or observational studies when reaching decisions in a pandemic situation? Real-world studies are important in a pandemic. For a new drug or for a new vaccine, randomized controlled trials can be done. But for interventions, it's very difficult if there are a group of interventions being done to determine which is the most effective or the effectiveness of one alone. Thank you. Professor Woolhouse.
Thank you. So for the reasons that David's clearly explained, models rather than randomized controlled trials are often used to try and disentangle the effects of interventions retrospectively, so to see what happens. The danger with that is what Ginetta was saying about the way the models are structured. So the way they're structured sort of imposes the answer. And I've already given you one example of this, where if the model assumes that the only driver of behavioural change is government diktat, government introducing restrictions, then that's what the model assumes drove. It's a circular argument. So it comes up with the answer that happened. The other thing about the models that were used during COVID is they focus specifically on social distancing. This is another example of how the structure of the model drives the answer. Social distancing. They didn't have the impact of all those COVID safety measures, the masks, the respiratory hygiene, the ventilation, the screens, all those things they do. They weren't in it. So the model gives you the answer when you apply it retrospectively that, the social distancing was the only thing that would work because it was the only thing in the model. And it had to be imposed by government because that was the only way it was built into the model. So it's dictating the answer to the question simply by the way the model's constructed. And this is basically poor science, never mind anything else. It's disastrous public health, but it's very poor science. And yet, I'm afraid quite a lot of that happened, certainly in the early stages of the COVID pandemic.
Thank you. Professor Bamber?
Thank you. I can think of a couple of pragmatic randomised controlled trials that were done around the role of masking during COVID, one in Bangladesh, I think, and one in Denmark, where they randomised people into wearing a mask or not in the community whilst everything else is going on. So it's kind of pragmatic, observational. But the difficulties they found were obviously how people use the mask, whether they were fitted correctly or not, and also low exposure to COVID because of the other restrictions. So one was inconclusive, the other found a slight, benefit for the mask group versus the other. But there were these, say, caveats, but limitations to doing the RCTs in a real-world situation. So you can get something from them, but not as much as you could get from the weight of other types of more observational evidence.
Thank you. Professor Gupta.
Yes, so 3 points. First of all, yes, I think that obviously RCTs are the gold standard or whatever, but it is important not to get so hung up on them as to say we're not going to do this until we've got that level of proof. You can't afford that. Generally speaking, I think in most situations, what science is more, well, it's like a jigsaw puzzle. You've got the observational studies, you've got some sort of poorly conducted RCT, maybe models which are imperfect in other ways. So it's like taking all these imperfect elements and trying to bring them together to create some kind of coherent whole. With regard, I could not agree more with Mark that, you know, the fundamental nature of how the models were constructed would give you the answer that you want. If you make the risk of infection proportionate to just any parameter times the prevalence of the infection, whatever you do to that will be reflected in the risk. So, in fact, one of the things that needs to be done, I think, is to actually examine that very fundamental assumption that the risk of infection is proportionate to the prevalence. But and I hope some more work is done in that area. But with regard to RCTs, and it's not an area of expertise at all, one idea that I had, which I'd very much like feedback on, is that outside of the pandemic is the time to do them. So, for example, any ideas that we might have now about how to protect care homes, we should be testing now, using perhaps something like influenza, rates of influenza, as an output. Those are things we should do in preparation for next time. And we should do it now. Would have been very difficult to do during the pandemic.
We've spoken about lockdown. I'd now like to ask you about the alternatives that may have been available in terms of non-pharmaceutical interventions or otherwise. Professor Heyman, if I could come to you first, what other tools were there available that could have mitigated against the need for lockdown?
I think we've already discussed many of them: infection prevention and control in health facilities, measures of making sure that care homes were shielded properly, that the staff working at those homes understood the messages that were being provided to them, and that they had access to the masks and knowledge and equipment that they needed, shielding of others who were vulnerable, especially those who were obese, because the obese were in fact at very high risk of serious illness from infection. And other measures such as personal hygiene, making sure that people were isolating themselves also if they thought they had been in contact, staying away from the elderly if they felt they had been in contact. Many things which can be done if communities are empowered to do it and if individuals are empowered to do them. So much of the effort should be actually on empowering individuals with the knowledge that they need in order to protect themselves and to protect others, as I'm sure you heard from the Swedish testimony. Also, other factors are physical ventilation, making sure that there are widely ventilated spaces, and getting people outdoors and having exercise rather than staying indoors and not having the exercise they need.
In your written response, you refer to the use of medical masks. Can I just clarify what you're actually referring to when you say medical masks? Medical masks, in my definition, are masks that are used in hospitals to prevent minor infections. They're masks that have usually a paper type filter here, not a filter, but layers of tissue, and then an elastic band. Thank you. And those were in short supply during the pandemic, and that's the reason that some governments gave for not recommending early on
that the population use masks.
And you mentioned in your written response, and indeed today, that there was evidence that those were effective to some degree. At what stage did the evidence of the impact of medical masks on decreasing the spread of infection become apparent?
Medical masks have always been known to prevent the transmission of infection. That's why they're worn by dentists, by nurses in areas of contagion. So there was no question that medical masks can prevent infection. They can prevent infection because they prevent the droplets containing the virus or the bacterium from spreading to others.
Was that the case, the efficacy in terms of COVID-19 or the SARS-2 virus?
The assumption at the start and the precautionary measure was, yes, that they could prevent the droplets. Droplets are non-specific, and droplets could be prevented by this, and they were being recommended in many different countries at the start of the pandemic.
Has that proven, are you aware of any research in respect of whether they were in fact, you're saying there was an assumption, but are you aware of any research as to whether they were in fact effective?
There were laboratory studies which showed that the mask could prevent the droplets containing the SARS coronavirus from passing through. Those studies were done in Hong Kong and in other countries as well. Maybe others on the panel know of other studies that were done in the laboratory.
And again, just one final question on masks, if I can press a theme. Are you able to comment on the efficacy of FFP3 masks in comparison with simple surgical masks, medical masks, in decreasing transmission?
I can't give you the comparison.
Thank you. Professor Gupta, do you have any views on alternative strategies?
Yes, I do. But we've talked about that already. It concerns very much, rather than trying to stop the spread, to protect those, to shield those who would suffer severe outcomes from infection. So it is difficult, it appears, for some people to appreciate that measures that can stop you from getting infected, and are very good at that, when applied at a population level, simply don't work. Now, let's not, or we can go into why they don't work, or they work in a very limited way. Of course, part of the reason is that you can't totally lock down a population. So if you can't totally lock down a population, and you don't know what the relationship is between partially locking down or degrees of partially locking down a population and how that will affect transmission, you actually are in a situation where if you lock down the population as best you can and it just doesn't work, then you're actually in a worse situation. You basically have done nothing than if you aggressively shield, take those resources and shield the people who would suffer a severe outcome. So this strategy was called focused protection by myself and a number of other people who thought it might be the better way to go, mainly because we were concerned about the effects of population-wide lockdown on the disadvantaged particularly globally. That strategy I prefer now to call individual risk reduction, and I think it should be predicated with something we've all been talking about, which is state-supported individual risk reduction. Now, whether that should be voluntary or mandated is another issue, so that's M or V. But state-supported individual risk reduction, to me, has to be, is a strategy that is robust to many of the uncertainties. So I'm not saying, what I'm saying is that a lot of things we didn't know, still don't know, but one of the things we do know is you can take someone and say, you stay at home over this particular period. We will make sure you don't lose your job. We'll make sure you get fed. But stay at home, do these things. Don't go to the supermarket, even with a mask on, because that wouldn't give you full protection. These can be done. And these are robust to some of these uncertainties of, can we actually stop it from spreading in a population? All those sorts of issues. And they certainly would avoid the enormous costs of lockdowns. So it seems to me that is what we should have implemented straight away in January 2020, is let's take such resources as we have to try and protect those who might end up in hospital and might lose their lives. And that's what would have also avoided the collapse of the health system, if that it was indeed imminent. So it seems to me that that's the strategy that is robust to all the uncertainties we have, would save lives and save the NHS, save and stop and prevent us from accruing all the enormous harms of lockdowns themselves. So the argument against that is, unless you keep infection levels very low in the population, it will trickle into the vulnerable group. And this, to me, whereas if you keep, so the benefit, so it's almost like a sort of trickle-down epidemiology idea that if you protect the general population, those who are vulnerable will also be okay. It's a bit like saying, well, if people get richer, then poor people will be better off, because, it sort of all trickles down. The benefits to the general population don't have the same relationship with the benefits to the vulnerable. I think under those circumstances, it's more important, it would be better, just as it would be better to actually lift poor people out of poverty, it would be better to shield vulnerable people than to expect some sort of population-wide lowering of risk to trickle down to them.
It's inherent within your description, I think, that you referred to state support, so there is the involvement of the state in terms of providing that support. But in terms of the individuals, do you envisage that would be a matter of personal responsibility for the individual to seek that help? How in practice do you envisage that working?
Well, I mean, furlough was implemented. People were, it would require some effort to educate about risk. So once you'd have to, I mean, there are lots of questions to be answered here, but, there are some people who are clearly at high risk. There are people whose risk is not so clearly defined. Those at high risk should be, all of the people who perceive themselves to be at risk, I think, should be offered, provided that's reasonable, their own assessment of risk, would be offered the ability to isolate themselves or to reduce their risk of infection as much as possible through state support. And so that would require, obviously, some sort of intervention. But I mean, that sort of intervention is what happens. You get letters through your through post saying, "Come in for to have your breasts screened." Come in. You can contact. That's the whole idea of having even in the dregs of the welfare state will still, I think, allow for that kind of involvement of the government in protecting those who are vulnerable. I mean, if in January everyone over the age of 75 had been told, look, there's this new virus around, if possible, or not if possible, we strongly recommend that you stay at home, and we will make it possible for you to do that. And then people who had comorbidities could have been told or obesity could have been told, you stay at home, and we will provide the means for you to do that, should they still be working or need to go out, so to be furloughed.
That's a very interesting proposal, Professor. I'd like to ask one question. I think I'm aware from the evidence I've heard over the past several years that pandemics can, of course, be caused by a number of different infective or viral factors, and the same planning will not, or one form of planning will not cover all potential diseases that could strike us as a pandemic. The proposal you're making, is that habile? You're very careful the way you framed it, I noticed. Is that habile to cover all potential pandemic causes, or would we need to have a variation of this for every pandemic plan?
Oh, certainly, that would be very, and well, that would be foolish, really, to say that same strategy would apply to everything. In this particular instance, where there was such a clear stratification of risk, where we could identify who was vulnerable, this was I felt the appropriate strategy. In other situations, it might be much more useful to do something completely different, such as in the Ebola case, obviously, that's completely different.
And I suppose following on from that, plainly, there are a number of potential causes of pandemics about which epidemiologists have knowledge and could either predict the most vulnerable groups, or certainly could take informed, I'm not going to say guesses, but informed estimates of the likely groups. And therefore, remember, I've got to make recommendations, and I can't, from what you've just said, make a recommendation that would cover all groups. But it would be possible for, with the assistance of epidemiologists, to frame a policy that would give the best advance guidance and protection for that suggestion.
I think the fundamental principle here is to find a strategy that is as robust as possible to the uncertainties. And so in terms of a recommendation, it would be to try and gain as much information on individual risk right at the outset, and see if we couldn't tailor it to the protection of those individuals. My own feeling is that, and this is a bit more, the reasons for this are a bit more complex, I think that because of our continuous exposure to pathogens through international travel and whatnot, that actually we have much more protection in the general population than we might have enjoyed before before demographics changed so much, because I think that cross-protection against severe outcomes from the other circulating coronaviruses played a very important role in protecting the general population. Influenza, I don't think, will ever return in the shape that it did in 1918, because we are now continuously exposed to influenza. Doesn't prevent reinfection with other strains and other subtypes. But I think the scale of mortality we saw in 1918 derived from a lack of exposure in the 30 years before. There was a pandemic in 1890, yes, exactly. So I think we're out of the woods in some ways. I know it's maybe too optimistic, and tomorrow some awful disease will come and prove me completely wrong. But I think we can be optimistic that the sorts of viruses that emerge, and the reason they have a difficult time emerging, I think, is because we do have these sort of barriers of cross-immunity. In this current sort of international global setting, I think the types of viruses we will see coming through as pandemics are more likely to be like SARS-CoV-2, where those who are either immunosenescent or have other complications are more likely to be vulnerable. But That's me perhaps being optimistic. But either way, in a more general sense, if we can identify those who are at risk, and let's hope that future pandemics, we don't have a situation where everyone's at risk, or if a new virus arises where children are at risk, we're in a completely different ballpark. But for this particular scenario, I think that was the solution that was most robust to uncertainty.
Thank you. Thank you, Bob. His Lordship's identified that there was a certain degree of identification of those at risk, for example, through shielding. Can you describe for us, Professor Gupta, what is the material difference between what you're describing in terms of individual risk reduction and what might otherwise have been understood to be shielding during the recent pandemic?
I don't think as such there's any material difference in that, you protect the vulnerable person. I think that shielding, again, these terms come with all sorts of, baggage, and shielding was reserved for people who were immunocompromised mainly, I think, rather than, whereas individual risk reduction applies to, so it is more diffuse in terms of who it might apply to. So, if you are over a certain age, you could say this is your risk, which is, it's less tied to your particular condition. Shielding seems to have this implication that it's tied to a particular disability almost. But I think these are sort of, semantic in some senses. I suppose a more pertinent question is, in terms of how could it be implemented is to do with multi-generational households, and maybe we want to come to that later. But
well, I was going to come to it next,
right.
so
Okay.
if you want to...
Yes, exactly. So given that, what we're talking about is not something that if shielding is a term we reserve for people with a particular condition that could be broadly thought of as atypical, whereas individual risk reduction is something that would apply to an elderly person living in a multi-generational household. How do we achieve that? And it's, of course, very difficult to answer that question, but I do think that in the extreme where, you've got very high rates of infection in the population, and I do think monitoring the population is crucial to affecting individual risk reduction, focus protection properly. I would say that in periods of very high risk, it would be reasonable to evacuate that person. We do so in times of war, in times of crises. So for short periods, again, what's sustainable and what isn't, for periods when infection levels are high, imagine that evacuation of of a vulnerable individual within that sort of setting, and doesn't have to be multi-generational. You could have someone who needs shielding who is not a multi-generational setting. But yes, solutions. No one is suggesting that this is straightforward in some ways it is straightforward for two 75-year-olds who are living in a nice little cottage somewhere. And indeed, in that sense, it's just a subset of lockdown, stay at home. But there are settings in which it would be a challenge, but, it's also a challenge in care homes. And one can think of creative solutions whereby people, you circulate the staff who then isolate previously for a couple of weeks. And there are all sorts of solutions that would require some thought. It's not a trivial thing to say, but I think overall they would be easier to effect than shutting down a population, and we know that they would be effective, whereas we have no certainty. In fact, actually, now we have various reasons to believe that population-wide lockdowns very hard to implement, and it's questionable that they do stop the spread. So if instead of stopping the spread, one were to protect those that might be affected by it, and one thing to remember is also that this is, with regard to sustainability, that this is not something you'd have to do forever, because as we settle into an endemic state, that that feature of the disease, of the infection, disappears. So you no longer have vulnerable elderly people because they've all already been exposed already. So it's just a temporary measure, and also, of course, not to forget vaccination as an eventual exit from that as well. I mean, one also has to have an exit strategy for focused protection. So, but these are all questions, policy, they're suggestions that need to be thoroughly discussed with a range of relevant experts, I think.
Just picking up on the question of evacuation, when you mentioned they are potentially evacuating during periods of high transmission and perhaps only a few weeks, in your written response you also suggest the means to evacuate vulnerable individuals should have been put in place until a vaccine was available. Now, as I understood Professor Woolhouse's evidence, that at the time might have been 4 years, less than a year was hoped for but not expected. In those circumstances, would you be expecting, or do you think it's realistic for people to be expecting to be evacuated for their home for that period of time?
No, but within those 4 years, well, by the end of those 4 years, it would have become endemic anyway. But you'd have waves of high risk. I mean, there would be shorter periods, but generally speaking, the problem of shielding people who are vulnerable, it still exists. It hasn't gone away. That because it's become endemic and because of the vaccine, those who can take the vaccine, which many immunocompromised people can't, are no longer at risk. But we still have immunocompromised people in the population who can't take the vaccine and who are at risk still. So, I mean, what we need to really focus on are therapies for these individuals, of course, and invest in that. With regard to the vaccine, yes, I think a remarkable job was done to get it through as quickly as it was. But I think that given that what I expected of the vaccine anyway was simply a reduction in severity of disease, that could have been, and I mean, we can be optimistic now that with other pathogens, if that's our goal, again, to reduce, that we can do that in a year.
Again, just going back to the question of evacuation, you spoke about identifying and informing and educating individuals. I mean, would you be envisaging evacuation to be a mandatory or a voluntary approach in terms of the individuals?
I think that, first of all, that we can cut it down to more finely even. I mean, as Mark pointed out, the likelihood of someone, if people in the household are tested regularly, if we have other protocols, I mean, there are other ways of reducing risk. And there are other issues to consider which weren't, even in the handling of our elderly, the care home residents, for example. So what we did is sort of adopt more of a sort of leprosaria approach, where you might get infected, and you say, I mean, it was done in the name of protecting them, but the elderly was sort of pushed away. So one wouldn't want to put in place something that obliged someone who would really rather live out their last few months or years within their own the setting of their household, even with that risk. I think obliging them to move somewhere where they wouldn't have that comfort would be very difficult. However, if we are willing to stop children from going to school and not getting, their only meal of the day, for the sake of the health system, our health system's not collapsing, it seems, if that's our attitude, then mandating vulnerable people to move to hostels or places, evacuating them, it seems very much within that sort of, the mindset that believes that we need to go, that the healthcare system needs to be protected at all costs, would surely permit the evacuation of an elderly person for 3 months, if it is perfectly happy to stop a deprived child from going to school for 3 months.
You mentioned hostels there. I mean, where would you be envisaging individuals would be evacuated to?
It seems we have no shortage of facilities for, obviously, to hotels, I suppose. It would have cost less to do that. 5-star hotels, of course.
Standing these individuals are obviously vulnerable individuals and maybe receiving care already. Do you consider that kind of approach would have an impact on existing support provided to individuals by, for example, social care providers?
Well, I mean, this is, so actually, now that you put it that way, it's essentially we're saying that people should be evacuated to, in effect, some kind of care home, actually. So then they are in a care home setting, and within a care home setting, I think it's absolutely essential that what we should have done is put in place the protocols that would allow visits, or certainly allow them to be looked after by carers, who would obviously have to go through a set of measures, possibly self-isolating for a while, for a few weeks, and then being tested rigorously, and then going to the care home, spending time in the care home, and then leaving the care home. The same sort of protocols would apply to these evacuation centres, I suppose. So essentially, I guess, now that you put it that way, that what I'm saying is that vulnerable people would be placed in a sort of care home setting over the period when the risks were high, which we could determine by monitoring, as we did, the R, the magical, monstrous R number. Now, I'm not an expert here, so I shouldn't really even be. I don't know. It's just my. But I do think that would have been a better way to address this, and I'm sure that the grandparents who might have been the subjects of this would have preferred that to their grandchildren not going to school.
Do you envisage that kind of approach? I mean, one of the things which His Lordship has heard a great deal of evidence upon is the situation of people in care homes already. Do you think that kind of strategy would have assisted in protecting those individuals? Particularly, not to put words in your mouth, but we may be moving more people into care homes in those circumstances.
Well, provided the care home was actually was an actual refuge, rather than being a prison, which would require a huge investment in the testing and isolation of the carers. And as I said, you'd have to have some kind of rolling structure to bring people in, put them through, then they leave, and then they come back in. And also you'd have to have some measures in place so that people could visit, which again involve a lot of testing and isolation. I mean, this isn't rocket science, I think. It's just, and that would require some investment. But I think that's what we'd have to do in care homes.
And sorry to press you on this, but just to be clear, you would be in favour of potentially mandating people to take these steps as opposed to leaving it to the individuals?
No, I wouldn't be in favour of that, because I do think that, you know, personally, I'd much rather, if someone told me I couldn't see my children, I can't even think of the risks that I would take to be with my children, you know, far in excess of the risks of COVID. So I think it would be very difficult. I personally wouldn't be in favour of mandating it, but I can see how, if you had to rescue a health system, that you might mandate certain aspects. I mean, given the proportion of people who we're talking about who live in generational families, I think that it would be better to mandate it for those who don't, who are perfectly able to self-isolate because they are a couple who are in their 80s or whatever, and it's all right for them to talk to their children, grandchildren through Zoom for 3 months. Or you could issue, as the Singapore government did, they issued iPads to the elderly to say, look, just don't see your children for 3 months, but here's an iPad, so you can talk to them. Solutions could be found, but with the whole issue of mandating, I mean, it's tricky. I mean, it's difficult. I mean, obviously one would prefer everything to be voluntary, but you know, we live under a social contract. So sometimes, unpleasant as it may be, mandating something, if it is for a short period of time, maybe for the greater good.
Thank you. Professor Heyman, you've been very patient since you indicated to me that you wanted to come in on a point.
This was to go back to the point of masks. I wanted to make it clear that mask wearing is not an effort to protect oneself, but to protect others. And that to protect oneself, you use PPE, which is personal protective equipment, which also covers the eyes. And the biggest difficulty during the pandemic was to have people understand that mask wearing did not protect them, it protected others from them. And so I just wanted to bring that out in this discussion, which I hadn't brought out previously.
Thank you.
Thank you.
Professor Bambra, if I could come to you next. We've spoken about the additional measures that could be put in place to protect vulnerable communities. Do you have any comment about whether it's important for people entering those vulnerable communities, such as, for example, police officers or social workers or the like, whether they are given appropriate PPE and indeed mandated to use it to mitigate transmission into areas of such vulnerability?
Well, that's not something I've considered before. So do you mean if we had police officers going into care homes, or do we mean going into, I don't know, a
communities,
London neighbourhood or something?
Yes.
Well, I think it would be fine if they were to be masked, for example, because of the evidence around masking. So yes, it would be mandatory, yeah. But you know, like I said, this is not something I've particularly considered, so I'm not sure I'd go on what I've just said without looking at the evidence. But obviously the evidence from the Royal Society did a fairly thorough evidence synthesis, I think it was in 2023, looking at, you know, masks, ventilation, test and trace and so on. And they did find the overall balance of the evidence observational and where there were these pragmatic trials, laboratory and so on, showed that the masks could be effective in reducing transmission. So it would therefore seem to be a sensible next step for that to be used in those kind of circumstances.
Do you have any comment about the alternative strategies that could be adopted, alternatives to lockdown, and in particular any effects that those might have on inequalities?
Yeah, the fact that we are aware, particularly now, of evidence, as I've mentioned, of other approaches rather than full-on strategy. So the other approaches, we've heard this morning that it was very much framed in scientific discussions at the time of lockdown or kind of nothing, and then we've heard alternatives to that, and some of the alternatives are what I'd be considered more traditional public health methods around the use of masks, around the use of test and trace, and self-isolation. And so then within that, you need to be able to make the conditions and the context in which everyone can take part in those actions and benefit from those actions. So I used the example earlier about self-isolation is only feasible if you can afford to self-isolate and you're supported in order to do so. So there are inequalities implications. And you may then end up, for example, with some exemptions around who has to mask and who doesn't. If you know, whether you would mask, for example, if you had hearing impairments and things like that.
Do you think, one of the matters which is inherent, I suppose, within what Professor Gupta has been telling us about the individual risk reduction is the question of state support. Do you think that is central to being able to undertake these alternative strategies?
I don't know whether all of the alternative strategies that are outlined would be effective or not, because that's outside my expertise. But in order, I just refer almost to the answer that I just gave, in the sense that yes, I would feel that you do need to have certain mechanisms in place in order that everyone's able to do what you want. And ultimately you want everyone to do it because you're trying to control what is a collective issue of an infectious disease. So we talked about individual risk, but we haven't talked that much about social risk and community risk. It is a shared risk, and it's about not just, this is my individual risk, because you are also able to transmit it as well. So there does need to be that reciprocity and solidarity within everything, and therefore that extends, in my view, to financial support where needed. And obviously there were, as I talked about earlier, some good examples from the early stages of the pandemic in the UK, but then they were removed potentially too early, and certainly too early from a longer-term public health perspective.
Professor Gupta.
Thank you for. I'm confused by the word solidarity here, because when I talk about individual risk reduction, to me it is the most communitarian approach that you can have, that it reduces the risk, the harms to the rest of the population, the harms to the young, harms to the poor, is reduced by keeping restrictions on to reduce individual risk. So where does the solidarity here? Individual risk is not an expression of individualism. It's a communitarian way. It's a way of enacting a communitarian solution.
So I took the individual risk meant that when we're talking about messaging, about people's understanding of what they should do or what might happen to them. We've talked this morning about how everyone was told that they were equally at risk, but actually there were different risks depending on your socio-demographic or clinical aspects. So I was talking about that, not about the proposed alternative that you were talking about that has those words in its title.
Okay, so
I think we're talking across purposes, basically.
Mm-hmm. Right,
yeah.
Because I think, I'm saying this partly because there were these ideas about focus protection being an individualistic strategy, simply because it was one that was robust to person-to-person transmission. But person-to-person transmission, I think it's that doesn't make it an individualistic strategy, that you're shielding the people who are vulnerable, and not by actually shielding them rather than trying to stop the spread in the community. Because the latter may be unachievable and comes at a very high cost. So believing that that's the only way to do it is not necessarily more communitarian than shielding the individuals.
No, I was talking, for example, around mask wearing, where it's not protecting you, but it's protecting, in effect, someone else. So that's the solidarity element. I'm not wearing the mask to protect me. It's uncomfortable, it's hot, etc. It doesn't go with my outfit, whatever. That's to protect someone else. So that's a collective solidarity.
But I think with the mask, the protection to someone else, I think one of the things that we must remember is actually it's not just about protecting myself and protecting others. There's a continuum there. So if you wear a mask and you're going to see an elderly person, I think as a precautionary principle, it seems like there is a reason to do that. But to believe that wearing masks is going to necessarily stop the transmission in the community, I think is another order of inference that, I think we need to be very clear. So exactly how communitarian that action is, or, attaching words like solidarity to those actions, I think should be done with caution.
We can disagree.
Thank you. Lord, I'm conscious of the time. I was about to come to Professor Woolhouse. We will perhaps cocoon him until tomorrow.
Very good. We'll do that. Let me check. Is it 9:30 tomorrow morning? 9:30 tomorrow morning. Very good. Thank you all.